So uh, I began noticing that I needed to do something about patients of mine who are incarcerated because uh, um, the patients would uh, go into jail or even a residential treatment program, and where they're abstaining from whatever drug they're using, whether it's alcohol or opioids or meth or whatever, and then they'd be released and they would immediately relapse. But from my experience going to KCCC, that this is a good time for them to really get invested in recovery because they're getting good rest, regular exercise, regular meals, and before my patients would go into jail or these residential treatment programs, they usually just look terrible. They're just really struggling. And these are just beautiful people waiting to come out if they're just given an opportunity. However, they're also very vulnerable. So, in one interaction I had at KCCC recently, one patient told me, and the nurse I'm working with, Landon, that he had the money to get out on a bail bond, but he didn't have anyone he could trust to transfer the money. And I just overall, just putting myself in his shoes and thinking, how difficult would my life be if I had no one I could trust? And in the Kauai Rural Health Association meeting, I said, there's probably at least a dozen people in this room that I could call and they would bail me out. I mean that, so I have a very good social network, and a lot of these people are just very vulnerable, very isolated, and very uh, uh, at high risk for relapse. The same person said that, if I told him what it's going to take outside of jail before you start thinking about using, like 15 minutes, and he was like, no, probably only 12. So let's talk about the problem of relapse after being released from incarceration. So overall, the incarcerated population, according to the National Sheriff's Association, is a group that is highly likely to have problems with chemical dependency. About 63% of inmates struggle with some sort of chemical dependency, and 50% of those, so this is over 30% of inmates with opioids currently, according to recent data. Our KCCC warden estimated that about 70% of his inmates have a dependency history. And to address this problem, in 2017, the National Sheriff's Association began to advocate for pre-release medication-assisted treatment in jails. And by October of 2018, 30 states had some programs running, but not Hawaii. And even in those states where the programs are running, it wouldn't include all of the jails in those states. Many of them are limited pilot projects, just like the one that I started. The status quo is extremely dangerous. There are more opioid deaths per year in the United States than motor vehicle accident deaths. And for people who are incarcerated or in a residential treatment program where there is not medication-assisted treatment due to the break from using while they're in jail or what have you, patients gradually get more and more sensitive to the opioids, so that after their release, when they go back to their previous dose, they have a very high risk of overdose and death due to that than prior to incarceration. And so in the recent study that I note here, about 1 in 7 opioid overdose deaths are in those who were recently released from jail. So what are the risks and benefits of a pre-release medication-assisted treatment program? Certainly, it clearly saves money for prison systems because of reduced recidivism and rearrest rates and return to jail. Plus, it reduces illicit drug use in jail because when people aren't jonesing, in withdrawal, craving, etc., they're less likely to need to buy illicit drugs in the jail, etc. Certainly, as I mentioned, pre-release medication-assisted treatment reduces relapse, rearrest, and overdose deaths. medication-assisted treatment, unfortunately, has been criticized in some cases for being forced onto the patients by the courts as an alternative to jail time, and so it has to be done right. The ProPublica report, The Last Shot, I think is very illuminating, and it just gives some guides of, there's a right way to do things, there's a wrong way to do things, etc. And addressing this concern, limiting medication-assisted treatment to just naltrexone is problematic because any medication is not right for everyone. And so ideally you would have patients allowed to choose from a number of different treatment options that are right for that particular individual. So how effective is pre-release medication-assisted treatment? So in the January of 2018 published Lancet study of community-based medication-assisted treatment, there still, unfortunately, was about a 50% relapse rate with either buprenorphine or naltrexone injection. However, in another study of those who stopped medication-assisted treatment, 94% of those relapsed. So, overall in different studies, medication-assisted treatment definitely reduces relapse rates, both in a community-based and in a pre-release medication-assisted treatment-based population. In a study of the naltrexone injection, those who completed 5 monthly doses of naltrexone after release from jail had 0% positive urine tests and 0 rearrests, while those who did not complete an additional 5 doses of injectable naltrexone, 62% of those had positive urine tests and 31% of them were rearrested. So, this is a substantial improvement with just the naltrexone, and buprenorphine apparently should result in even better results. So the problem that we're trying to prevent are 3 things: relapse, rearrest, and also overdose. And overdose, of course, can result in deaths. So in Rhode Island, where they began an extensive pre-release medication-assisted treatment program, they noted a 60% reduction in deaths after release with the pre-release and post-release treatment. And in another study from 2018, they found that you only need to treat, for those people who struggle with opioid dependence, 11 inmates with pre-release medication-assisted treatment to prevent 1 death. And in California, the administrator of their prison healthcare system, did note that the dead don't recover, and that helping people prevent overdosing and dying really improves recovery rates, obviously. And as I mentioned a couple times already, some pre-release medication-assisted meds are better than others at reducing deaths post-release. So buprenorphine seems to be more effective at reducing relapse, rearrest, and overdose deaths than naltrexone, although naltrexone obviously is effective. So what is new in this area? One thing is starting last year in about the middle of 2018, Sublocade, which is a once-a-month high-dose buprenorphine injection, was released. And at my practice, we've administered it to a number of patients with severe opioid dependence. This is, probably, of the 170 some patients that I currently have in my Suboxone program, this is probably 5% of that population, and it actually has been very effective. I expected that meth use and alcohol use would skyrocket after blocking people from using opioids with the Sublocade, but really the results have been phenomenal, that the vast majority of patients who start the Sublocade injection do extremely well, And I've been very happy with it, to my surprise. I really didn't think it'd make that much of a difference. Unfortunately, currently because it's so new, there are no studies of pre-release medication-assisted treatment with injectable buprenorphine, otherwise known as Sublocade, and it's also $1,800 a dose. What else is new? In this year in May in Boston, the Federal Court of Appeals ruled that not offering treatment, specifically buprenorphine, for chemically dependent inmates violates the American with Disability Act. That this is a bona fide medical condition. There are effective known treatments, and that not offering it violates people's rights, not only under the American with Disabilities Act, but also because of the risk of death due to overdose after release. We have a constitutional right to treatment, because not treating people is cruel and unusual, because 1 in 11, according to these other studies, will die after release. And so it's basically like a partial death sentence to not offer people effective medication-assisted treatment pre-release. So there are some international studies that show 75 to 85% reduction in post-release deaths with buprenorphine-based treatment, as opposed to the Rhode Island experience in the United States, which showed a 60-some% release. So this is something that's been studied in other countries numerous times. So finally, as noted at the beginning of my presentation, the National Sheriff's Association and the National Commission on Correctional Healthcare published a guideline about how to institute a pre-release medication-assisted treatment program in jails. And basically, they said this needs to be done, and this is how you do it.